Thank you very much, and thank you for inviting me to come and talk to all of you. I've got quite a comprehensive presentation, and so I'd just like to get an idea of who's in the audience. Are you all doctors who are practicing in the field of HIV medicine, or are they other categories of health worker? Psychologists? Primary healthcare nurses, yes. Medical technologists. HIV research, you're involved in HIV research.
Employee readiness coordinator.
Okay, all right. So basically this is a very comprehensive presentation which includes both the neuropsychiatric aspects of HIV infection. It also includes the interface between HIV and serious mental illness, and then the very big area, which is my area of special interest, which is HIV and common mental disorders, which are mainly depression, anxiety, and substance use disorders. So I'm assuming that all of you have got baseline knowledge in HIV and the virus and what effects it has in the body, and I'm going to focus in particular on what effects it has on the brain, and then look at some of the other mental disorders associated with it. So I'll cover some bits about HIV in South Africa and about mental disorders in South Africa, just to give you a context, talk a little bit about HIV infection and the brain, and then look at the relationship between HIV and mental disorders, look at ways of preventing, identifying early, and treating effectively patients with comorbid HIV and mental disorder, and then some aspects around managing patients who are on antiretroviral medication and on psychiatric medication. We all know that about 17% of the adult population is infected with HIV, and that in 2008 the HAART treatment gap was about 48%. I've been trying to find more up-to-date data. I'm sure it's considerably less. However, I think we still do have a treatment gap. And HIV is considered now a mature epidemic where the number of new infections is just about equal to the number of deaths. It affects all sectors of society, but particularly poor and vulnerable groups. And in those vulnerable groups are women, refugees, displaced people, and people with serious mental illness. We all know about the economic impact on society, and we can all imagine the psychosocial impact on families and children. And we are all, I think, very excited about the new approach to managing HIV in the government, and the HCT campaign, which kicked off in April, which aims to test 15 million people over the age of 2 years by next December. And obviously there are serious logistic issues around that, but at least we've got the will now to try and tackle the problem. Just looking a little bit at the statistics for Gauteng, this was also in 2008. The prevalence in the whole population was 15%. And again, the number of deaths almost equaling the number of new infections. If we look at mental disorders in South Africa, there's sort of three main categories. And that is mental disorders that are secondary to a general medical condition or to substance use disorders. And obviously, the prevalence of those disorders is dependent on the prevalence of the underlying medical conditions and the substance use disorders. With HIV and with the high prevalence of substance use disorders in South Africa, this is quite considerable. In terms of serious mental illness, these disorders can include things like schizophrenia and other psychotic disorders, bipolar mood disorder, major depressive disorder, and the severe anxiety disorders. And generally, you'll find globally across countries that about 3% of the population at any point in time suffer from a serious mental illness. And then common mental disorders, as they are called common mental disorders, obviously more common, and as I said, include depression, anxiety, and substance abuse. There's very little accurate data on prevalence of mental disorders in South Africa. But recently there was a study done which is linked to the World Mental Health Survey. So it's a similar study that's been done in a number of countries across the globe. And the study in South Africa was called the SASH study, which was the South African Stress and Health Study, with a particular focus on post-traumatic stress disorder and the repercussions of violence and trauma that people had experienced during the apartheid era. But from that study, we've been able to get some reliable figures on the prevalence of common mental disorders. And in this study, this was all people over the age of 18 years, 17% of them had had a common mental disorder in the past 12 months at the time that they were interviewed. 30% of them had had a disorder, a mental disorder, common mental disorder at some time in their lives. And looking at the group of children under the age of 18 years, 12.8% of them had had a history of a mental disorder at some point in their lives. So you can see that the prevalence is quite high. Common mental disorders are impacted on by social circumstances such as poverty, social transition, economic inequity, recession, crime, and violence. And in South Africa, I believe we've got intersecting epidemics, because we have an epidemic with HIV, but we also have an epidemic of mental disorders. And the two do combine to create some specific challenges for us. I'm not going to go into the virus, but just to maybe just highlight that in terms of the HIV virus, you've got the various classes, and then within the classes you've got subtypes or clades which have been identified. And these seem to be different in different geographical areas. Clade C seems to be prominent in Southern Africa, Ethiopia, and India, whereas clades D and A are more prevalent in Eastern Central Africa. And it's supposed that different clades affect disease progression. And for example, that with the clade D, there may be faster progression and there may be more neurological complications. And this will come up when I talk about some of the studies that have been done on HIV-associated neurocognitive disorders in Africa. Just to emphasize that HIV infects all cells with CD4 receptors, and that includes glial cells in the brain. Those are the monocytes and microglial cells and macrophages that are in the brain. And as you all know, the virus replicates itself in all these cells, and in the process, these cells are destroyed. And again, just to highlight that in the initial infection, during the acute seroconversion illness, that this is the time when there's infection of the central nervous system. And during the process of the acute seroconversion illness, there's this interplay between virus replication and the host attempts to limit the virus. The person ends up with a viral set point, which is a balance between viral replication and host defenses. And depending on where that set point is, that affects progression. So clinically, you get deterioration when the virus replication overcomes the host's ability to protect the body. And you're all aware of the WHO clinical staging system. Then just to move on to the CNS, there has been some controversy about how the virus gets into the central nervous system. There are two theories. The one is that the virus infects cells that are circulating in the bloodstream, in the body, and then move across the blood-brain barrier and infect the brain in that way, or that it may, the virus may cross the blood-brain barrier directly and then infect those cells in the brain. And the current thinking is that it's probably the first, the Trojan horse theory. So what happens in the brain is that you get replication in these cells, and these cells are meant to support and nourish the neurons, which are the working cells in the brain. But what happens with the replication is that there's a release of various toxins during that process, and particularly when those cells get destroyed. And that cascade of neurotoxins then damages the neurons. And that is how the brain actually gets damaged and how dementia develops. The other thing that's important to note is that because the brain is protected by the blood-brain barrier, there's concern that if the drugs that are used to treat the HIV don't cross the blood-brain barrier, that then the CNS may become a reservoir for HIV infection. So these are some of the mechanisms that cause damage to the brain. There's release of cytokines, excitotoxins, free radicals, impairment of host repair mechanisms, and then also damage to the blood-brain barrier. And what happens is that you get a productive brain infection in these support cells, and the neuropathology is you get large multinucleated giant cells which then die, and then you get the indirect damage to the neurons. The neurons, dendrites become injured, and there's simplification of the dendrites, and ultimately, in the long run, the neurons die. The site of damage predominantly is in the white matter of the brain. So the areas that are predominantly affected are the subcortical areas in the middle of the brain and the deep gray matter of the brain. So there are gray matter sort of collections, the basal ganglia, the caudate, and in the hippocampus, which is in the temporal lobe. And those also are primary sites of damage. Now, when you talk about the hippocampus, that's the seat of psychiatry and of psychiatric disorders, because that's structurally where those disorders arise. So you can already begin to see that if HIV is causing damage there, that perhaps some of the presentation is going to be psychiatric in nature. As the disease progresses, there's progressive cortical atrophy, and the pathology that is seen is the atrophy, particularly in the striatal and frontoparietal areas, but then becoming more generalized. There's also this idea of different types of cells that in the CNS may be what are called productive or restricted. And the productive cells are considered to be those that actively produce the virus and then die. Whereas the restricted cells they're permissive to the infection, but they're refractory to the virus replicating rapidly and expressing itself. So they don't die, but then they may act as reservoirs for the infection. So this may be where the virus may survive and then be reactivated later when maybe there's a change in the cell environment due to the levels of cytokines or some problem with the immune system. So that's some of the biology and neuropathology. Obviously, HIV infection also has significant psychosocial implications. It's a life-threatening illness. If it's untreated, it leads to other illnesses. It causes pain, suffering, and early death. And it affects mainly young people who are of childbearing age in the prime of their lives. And the illness and death as a result of HIV causes disruption of families and an increased economic, social, and emotional burden on families. And aged parents, siblings, and children are the ones that are really bearing that burden. It still remains a stigmatized illness, and there are questions about why should HIV be such a stigmatized illness? Is it because we don't like to talk about death? So any illness that causes death we don't like to talk about, so we don't like to talk about cancer? Or is it because it's sexually transmitted and we don't like to talk about sex? But whatever it is still stigmatized. And the result is that many people who are infected don't know their status and they don't access treatment. And in addition, people who do know their status often find it very difficult to talk about because of the stigma and because of the implications of the illness. And treatment of HIV has brought some relief, but the implications of long-term treatment are still considerable. So the kinds of psychological reactions that people have to discovering that they are HIV positive need to be differentiated from the mental illnesses that they may experience, because this is similar to the kind of reaction that anybody has to bad news, whether it's another kind of life-threatening illness or whether it's a bereavement or some tragedy in their lives. And there's a fairly typical progress of psychological adjustment that occurs after someone receives bad news. One needs to remember that receiving bad news may be superimposed on existing stresses in the person's life, and may also be superimposed on existing mental disorders or vulnerabilities. And it also needs to be remembered that individuals have different coping styles and different levels of resilience, so that one person may cope with a lot of stresses and overcome them, whereas another person may not. So everybody's different. Dealing with bad news, the process is similar to the bereavement process. And I'm sure lots of you have heard about Elizabeth Kubler-Ross and her bereavement process that starts with shock. Then the person goes into denial, then there's a period of bargaining, then there's a period of depression until one reaches some kind of level of acceptance. Not everybody moves through that process. Some people get stuck. Not everybody even begins the process. And how people process this information and deal with it depends on themselves, on the resources they have, and the levels of support that they have. And it may take one person 3 to 6 months, it may take another person 2, 3, 5 years. So it varies. And the question, I think, when you're working with people with an illness like HIV is how much is normal that with support and counseling and getting treatment and keeping well, this person will adjust, and when do you intervene? How do you know when to intervene? So I'm hoping that that's some of the discussion that we can have tonight. I think the question of whether there is a relationship between HIV and mental disorders, we know the answer to. Prevalence studies of mental disorder in HIV-infected individuals indicate that there's a higher prevalence of mental disorders than in the general population. And there are two questions. Are people with mental disorder at higher risk of becoming HIV infected? And I think the answer to that is yes. And does being HIV positive increase the risk of developing a mental disorder? And I think most definitely the answer is yes. So what are the mechanisms? Why is there increased mental disorder in people living with HIV? As I've spoken about, it may be as a result of direct infection of the brain, or the other associated general medical conditions that you get with HIV, or the treatment of those conditions, of the HIV itself, or, for example, treatment of MDR-TB. Obviously, the psychosocial stresses may cause mental disorders to develop. And the other thing to remember is that there's a certain prevalence, as I mentioned, of primary psychiatric disorders like schizophrenia and bipolar disorder. And the time of presentation is in young adulthood, same time that people get HIV infected. So sometimes there may be two separate conditions. The person maybe has a bipolar disorder and is also HIV infected. So those are the three categories of psychiatric syndromes. They're the HIV-associated neuropsychiatric disorders, HIV and serious mental illness, and HIV and common mental disorders. And I think a general approach should be that if you're seeing a patient who is HIV infected over a period of time, if there's any change in their mental state, the first thing you must consider is there's some general medical condition that's causing this change in the mental state. In practice, when patients present with psychiatric symptoms in the context of HIV infection, it's usually a combination of symptoms. So it's usually a mixed picture of cognitive symptoms, psychotic symptoms, and mood symptoms. And the treatment approach, as I've said, is to exclude and treat the underlying general medical conditions, but also to treat the psychiatric symptoms. And one needs to be aware of drug interactions and the reactions of people with HIV infection to psychiatric treatment, but one shouldn't be afraid to treat the psychiatric symptoms. You must treat them. In terms of a psychiatric assessment, one obviously does a full history, physical examination, and mental state examination. But I think if we're thinking about this as an emerging area where there are difficulties, that it would be useful for people to screen for certain mental disorders. So to screen for and identify neuropsychiatric impairment, and to screen for and identify common mental disorders. But then also to consider a cross-sectional versus a longitudinal presentation and being aware of what a normal psychological reaction normal psychological reaction might be. In the developed world, with the introduction of HAART, the prevalence of HIV-associated dementia is around 10 to 15%. The MCMD is minor cognitive motor disorder, which is a less severe impairment, and that is at about 17%. The prevalence prior to HAART was a lot higher, as you can see. And the problem with neuropsychiatric syndromes in HIV is that they can be quite difficult to detect, especially in the early stages. They may present with a dementia-like picture, but quite often the most prominent symptom is psychomotor slowing, that they're just much more slowed down. And then they may present with these kind of mixed pictures of mood, psychotic, and cognitive symptoms. And the treatment for neuropsychiatric syndromes in HIV is highly active antiretroviral treatment, because the dementia is due to the HIV virus. So the treatment must include HAART. If we look at neurocognitive disorders in Africa, it's quite interesting to see what has happened over time. So, for example, in 1994, the WHO did a global neuropsychiatric study, which included sites in Africa. And in that study, they found a very low prevalence of HIV dementia. This was very early on in the epidemic, and I think what was happening is that people were dying before they got demented. In Uganda, in 2007, the prevalence of HIV-associated neurocognitive disorder was 31%, so it's significantly high. And they found that in those studies that being older and having a lower CD4 count were risk factors. On the other hand, a study done at a similar time in Ethiopia found that the patients there had higher CD4 counts and less cognitive impairment. And here it's thought that maybe it's because the clades are different. So the clade in Uganda is clade D, which is the more virulent one, whereas the one in Ethiopia is less virulent. It is conjectured that HIV dementia may become one of the most common dementias worldwide, ranking up there with Alzheimer's and vascular dementias. Some of the other studies that have been done in Africa are forensic autopsy studies. So in Tanzania in 2005, they found a lot of opportunistic infections in the autopsy studies, but HIV-associated encephalitis, which would be your marker for HIV-associated dementia, wasn't found. A similar study in India, again, found opportunistic conditions, but not HIV-associated encephalopathy or dementia. In South Africa, in 2005 as well, again, mainly opportunistic conditions, but this was not an autopsy study by Modi et al. This was a study done at Helen Joseph Hospital, and there they found 38% of people admitted with HIV infection had HIV-associated dementia. Just to talk briefly about the minor cognitive motor disorder, these are the kind of diagnostic criteria that one uses in order to make the diagnosis. And it's a mild impairment, and it may impact on the person's ability to work, but not on other activities of daily living. 17% of patients who have MCMD progress to HIV-associated dementia without treatment. But the problem is we don't know who is going to progress and who isn't. So there's a whole debate about whether you treat these patients with ARVs or not. The HIV-associated dementia complex obviously interferes markedly with both with activities of daily living and with work functioning. And the major areas that are problematic are attention, speed of processing information, efficiency of learning, and psychomotor skills. In terms of the cognitive impairment, memory and learning are affected, particularly short-term memory, concentration and attention, and executive functioning, which is basically what happens in your frontal lobes with your ability to plan activities and to problem solve. So the higher order functions are affected. Mood quite often is apathetic and depressed, but on the other hand, there may be patients who present with manic symptoms. Generally, behavior is withdrawn with decreased energy, but there may be disinhibition, poor judgment, emotional lability, and personality changes. And then there are also motor effects, the general slowing, clumsiness, unsteadiness of gait, weakness in the legs. You might notice a decline in handwriting, and then slowness of hand movement as well. So in terms of HIV-associated neurocognitive disorders, a full evaluation is obviously necessary, and one must treat the opportunistic conditions that may be clouding the picture. And then the other thing is also to always consider depression, because there's a very complex relationship between dementia and depression. And people who are dementing may actually become depressed in the early stages because they become aware that something's not right. And some people with depression may actually present as being demented. So one must always exclude a depression, and if one's concerned, treat it. How do you screen for HIV-associated dementia? Do any of you use screening tools to look for this? Okay. What we use in psychiatry to assess cognitive functioning that we've used over all the years is the mini mental state examination. So it's a series of tests, and you score it out of 30, and generally people should score 30 out of 30. The problem with the MMSE is that it tests mainly cortical functioning. And we know that the HIV cognitive impairment is at least initially subcortical. Then there are two other screening tests. There's the International HIV Dementia Scale, which is a very brief scale which scores out of 12. And if you score less than 10, you should then evaluate this person for dementia. The problem with that is that if you're a clinician, I think if somebody scores 10 out of 12 on the IHDS, you can see that they're demented. It's usually fairly obvious. So it's not really clear how useful that is. There's another cognitive assessment called the Montreal Cognitive Assessment, and that is a more holistic cognitive screen, which also includes screening for subcortical functioning as well as executive functioning. So, in fact, in the Division of Psychiatry at Wits, there's a gradual sort of changeover from using the mini mental state to the MOCA, which is, we think, maybe a better instrument, and then particularly in people where there's a suspicion of HIV neurocognitive disorder. Quite an important point, and this doesn't only relate to HIV, but in general, when you're trying to work out is someone depressed or dementing, that if there's subjective cognitive complaints like I can't remember things, I can't do this, my brain's not working anymore, that correlates quite significantly with mood symptoms. And that people who actually have cognitive impairment may actually be less likely to report difficulties because they may not actually have the insight into their poor functioning. The International HIV Dementia Scale originated from the HIV Dementia Scale. This one, it was considered that there was quite a significant influence of education and culture on the scale. So it's not really used that much, although a study was done in South Africa that found that it was fairly sensitive. This is the International HIV Dementia Scale, and so it tests memory, motor speed, psychomotor speed. And as I said, you score out of 12. And normative data for the scale have been produced in Uganda and Ethiopia, and I think quite soon there will also be some from South Africa. These are the kinds of bedside neuropsychological tests that you could do. You want to test orientation and attention. And the way we test for attention is what we call serial sevens. So you say to the person, subtract 7 from 100, and then subtract 7 from your answer, and 7 from your answer, and you see how well they're able to do that. If there's a problem with low levels of education, then you can do 20 minus 3, or you could ask the person to spell world backwards. So there are various adaptations. And then you want to test, in terms of memory, the registration. So you'll give the person 4 words and ask them to remember the words, and then get them to repeat them. So you make sure that they've actually registered the words. And then you say, I'm going to ask you in a few more minutes to tell me those words again, and then you go and do some other testing, and then you go back and ask them to recall the words. and they should be able to recall after 5 minutes the 4 words. Another test of frontal lobe function is a test of verbal fluency. So this is how easily is the person able to think of words. And we use the word generation test. So you say, give me a list of words beginning with the letter F, with the letter A, with the letter S, or list of 4-legged animals, or, you know, that kind of thing. And then there are tests for psychomotor speed, which are the one that's used in the International HIV Dementia Scale is you ask the person with their non-dominant hand, I'm left-handed, to do the sequence of movements. Okay? And they should be able to do the 4 of those in 5 seconds. They have to learn how to do it, and obviously you'll assess how easily they're able to learn how to do it, and then the speed with which they're able to do it and if there are errors. But critically is to look for slowing. If they're slow and not able to do things in the required time, that's a problem. So the MOCA basically does have a lot of these tests that I've spoken about, but it's in a more structured way. And in terms of investigations, if you suspect that someone does have HIV dementia, you would obviously need to look at their cerebrospinal fluid to exclude other causes, CT scan. An EEG is not usually useful. However, if you think the person has a delirium, then an EEG is quite useful to look for slowing. And there is also quite a higher prevalence of epilepsy, of seizures in people with HIV infection, particularly where the brain is involved. So as I've said, the treatment is antiretroviral therapy. And as you all know, it's critical to reduce viral replication to being undetectable. But other aspects of the management of dementia are obviously important. So you need to treat the general health of the person. You may need to treat psychiatric symptoms. You may need to look at home care and supervision and psychosocial support both for the patient and caregivers. Some kinds of behavioral management and cognitive retraining may be useful, and obviously financial support. And if there are continuing cognitive symptoms, again, think about depression. So currently our treatment policy in South Africa is based on CD4 count, but it's also on the presence of an AIDS-defining condition irrespective of CD4 count. So if someone's presenting with HIV-associated neurocognitive impairment and their CD4 count is not below 200, they need treatment. And the literature from the developed world is that the earlier you start treatment where there's cognitive impairment, the better the outcome. If you leave it too late, then you get irreversible brain damage. And that's now coming out very clearly. And in other countries, they're starting generally, I think, HIV treatment at a higher CD4 count, but particularly where there's neurocognitive impairment. Now, obviously, there are problems. If someone's got neurocognitive impairment and they've got to take a very complicated regime of medication, which may include HAART as well as psychiatric medication, that's a challenge. But it doesn't mean to say they don't have the right to get the treatment. We just have to find solutions to how to get adherence in that kind of situation. I don't need to go through this with you. I'm sure you know all these things. Maybe just to highlight in terms of the drugs that the one that seems to cause the most psychiatric symptoms is efavirenz. It's an excellent antiretroviral. It's most commonly, I'm sure you've seen this, causes insomnia and nightmares on initiation. Very occasionally it can cause very severe depression, usually on initiation of treatment. And it may be so severe that you would want to change treatment. But it's important to bear in mind that generally the mood disorder is transient. So you may rather consider treating the depression some other way and just trying to ride it through. But that's obviously going to be a clinical decision in each individual case. So the optimistic view is that with HAART, there should be less HIV-associated dementia, and some of the research to back that up has been done in Africa. The issue with the cognitive impairment is because people are surviving longer, there's actually an increasing prevalence of cognitive impairment. And the other issue is that there's only a 60% response of HIV dementia to HAART. And it's not clear, from the studies that have looked at this response, how much response you can expect in the early stages, and then, over what period of time, a longer period of time, can you expect recovery of cognitive functioning. And they particularly looked at studies looking at some of the CNS penetrating antiretrovirals to see whether they did better than ones that weren't CNS penetrating. But what they came back with was that maybe the trials were not long enough, and they actually needed to not go on just for a 6-week or 12-week trial, but it needed to be months, maybe even up to a year. So these are some of the questions that are still outstanding. And the one is the issue of, are ARVs that penetrate the brain better? Does the CNS become a reservoir of HIV infection if the ARVs don't penetrate? There's this whole question about, when you're treating HIV-associated neurocognitive disorder, what is still active disorder and what is now inactive and irreversible. So they're looking for biomarkers for active CNS disease, and so far have not come up with that many. But I think the other important thing is that the ARVs kill the virus, but they don't address the inflammatory cascade in the brain, which is what's causing a lot of the damage. So some of the research is now looking at neuroprotective agents that maybe would protect the neurons from the toxic substances from the inflammatory cascade. This is just a list of which are the standard drugs that are used, which are good penetrating agents. And those are zidovudine and nevirapine and the PIs. Abacavir, I don't know if you use it very much here. Okay, so that's also a good penetrator. Intermediate are stavudine, limivudine, and efavirenz. And then poor penetrators are tenofovir and didanosine. Okay, but I think when you're using triple therapy, we're not saying that every single one needs to be a good penetrating agent. You also need to look at how effective it is as an antiretroviral. And I'm sure that part of the recovery is also due to the systemic treatment and the systemic recovery. Some of the neuroprotective agents they're looking at are those that are being looked at for prevention and treatment of early Alzheimer's and other dementias. And then there's been quite a lot of work on memantine, which is also being investigated for as a treatment for dementia, but it's an NMDA antagonist. And some of the studies seem to suggest that it may be useful. But the question is, when do you use it? Do you use it from the start with the antiretrovirals? Or how do you know when you're actually needing to use a neuroprotective agent? Is it going to be when the antiretroviral has had its full effect? Is it going to be, if you don't have a detectable viral load, is there ongoing inflammation that the person needs protection from? Because if you use the memantine where there's already irreversible damage, it's not going to be that helpful. So it's quite difficult to know. And the current recommendations are really to give the person a good stint of treatment on HAART for at least 5 months, and then to consider whether maybe to add memantine or not.